Alrighty, good afternoon, everyone, and welcome to the Ask the Expert series of Women and Epilepsy. Today we have Dr. Maria Dorrington, which is an assistant professor at neurology at Yale School of Medicine. Thank you for joining us today. I'm gonna stop sharing my screen and then you can share yours.
It says I can't share.
Are you able to now?
Yes, can you guys see this okay?
Yes.
Great. Well, thanks for having me. As she mentioned, I'm Dr. Dortian. I recently joined Yale about a year ago. I finished my residency in Philadelphia, and then I did my epilepsy and clinical neurophysiology training in Boston. And so I'm just going to briefly talk about, women in epilepsy. I have no disclosures, just as a brief introduction. And, some of you might know these already, but seizures are basically sudden, uncontrolled bursts of electrical activity in the brain, and they can look like anything. They can look like your typical absences. The most common that people are very familiar with are convulsions, but I wanted to show you guys that they can look like anything, depending on which part of the brain is involved. So this patient that I had seen during my training had just presented with flank pain, and for several years they thought that he had kidney stones until we brought him into the epilepsy monitoring unit and actually diagnosed that he was having seizures from the part of the brain that is involved in sensation or pain. And so it can look like that, or it can look like something like this. This is a patient from Jefferson Hospital back in 2009 who had post-traumatic epilepsy, and his seizures were what we call these ictal dancing. And so, like I said, seizures can vary in clinical presentations. They can look like anything, and one patient can have multiple different seizure types. Epilepsy, on the other hand, is the inherent predisposition to generate spontaneous seizures. It affects about 5 million people worldwide. It can affect anyone from infancy to elderly. It can have multiple various etiologies. It can be genetic, it could be structural. One of the more common ones that we see in the adult population is a post-stroke epilepsy. It can be related to a brain tumor. It could be autoimmune. So lots and lots of different etiologies. So knowing that, with seizures and epilepsy presenting with different seizure descriptions, different etiologies, different ages, comorbid conditions, background, socioeconomic status, support situations, different genders, the way that we really care for patients is that we try and personalize their care. We try and understand a particular subset and make sure that we address everything for that individual. And one of my personal interests is obviously the different genders. And so throughout my talk, I'm going to talk about women, which will be persons with epilepsy of childbearing potential. I think women are, a good group of patients to study because, as you know, there's normal physiologic changes throughout a woman's life cycle, which are dictated by sex hormones. So there's puberty, there's pregnancy, and perimenopause. And in each of these different life cycles, which are normal physiologic changes, there are different parts of seizures or epilepsy that we try and understand. And like I said, the big sort of background for all of these is sex hormones and how they affect the different end organs. This is, what dictates our hormones are basically coming from your brain, and then hormones are basically like messenger molecules that go from the brain to your ovaries or to the endometrium. And the more common ones, are the ones that we really try and study and understand, especially in epilepsy, are estrogen and progesterone. Estrogen is thought to be the sort of the bad hormone because in some studies before, in both animals and in patients, or they've been thought to be proconvulsant, and so they sort of promote patients to have seizures. And progesterone is the good hormone, meaning that it's the one that sort of is protective of seizures and it stops seizures from happening. Is sort of how we understand it in general. And so with puberty and menstrual cycle, I'll start off. So as you can see here, again, this is a normal a woman's period, a regular one, is about 28 days. And I know this is a busy slide, but I just wanted to show you guys that throughout that cycle of 28 days, there's already fluctuations in the levels of both estrogen and progesterone. And these are sort of fairly specific, and we can recreate all of these. And we know that these are what happen. And so catamenial epilepsy comes from the word catamenias, which is Greek for monthly, are basically increased seizure frequency at a specific phase of the menstrual cycle. And again, we think that this is because of the effects of hormones and its changes throughout the cycle. We make this diagnosis really based on seizure and menstrual diaries. And basically, we need at least 3 months of a seizure and menstrual diary. And what we need to prove is that there is at least a twofold or greater increase in a patient's seizures during a certain phase of the cycle. So, for example, I'll have patients where I'll ask them what their triggers are, and they'll say, I typically have more seizures when I start bleeding. And so if we're able to document that for at least 3 months, then we make a diagnosis of catamenial epilepsy. And so why is this important? Oh, sorry. So the different types of catamenial epilepsy, like I said, so this is the red is progesterone, blue is estrogen, or the sort of the bad hormone. And M is menstruation, so when patients start bleeding. So the most common pattern is when patients have an increase in their seizure frequency around the time that they start bleeding. So either a couple of days before or at the onset of their bleeding. And we think that this might be because your progesterone drops around the time of menstruation. Another type is peri-ovulatory, so around here. And we think that this might be because your estrogen is so high. And remember, we think that some estrogen is proconvulsant. So that's one of the patterns. And then the other pattern is when patients have an anovulatory or an irregular cycle, which is also very, very common. And in these patients, they actually have much higher estrogen than they do have progesterone. And so these are the theories behind why we think there are these different catamenial epilepsy types. So I think it's very important to make this diagnosis because it can affect from 10 to 70% of persons with epilepsy. In a big trial that was able to enroll about 400 patients, what they did was they had these patients who had poorly controlled seizures document their menstruation and then their seizure frequency, and they also did hormone levels during these time for the baseline of 3 months. And then of those patients, they found that actually 44% had a catamenial pattern, or an increase in frequency of their seizures at particular stages of their cycle. So I think, if 44% of all women with epilepsy, it's a pretty big number, right? There's
Yeah.
no standard of care for these for when we treat these patients, really. And what it's been limited, the one that I showed you, that study of 400 patients, that's the biggest study that we have so far. All of these other ones that looked at an anti-seizure medication called clobazam that some of you guys might be familiar with. A lot of these are very, very small studies, like about 10 to 14 patients. So we don't have enough information about it. We're looking into hormonal treatments because we think that it's because of hormone changes. So we're looking at maybe the intervention isn't another seizure medication, maybe it's hormones. So when I was at Brigham, when I was at Boston, what we looked at was this progesterone. It's called norethindrone acetate. So it's FDA approved and it's available. It's indicated for abnormal uterine bleeding. And our hypothesis was that when we suppress ovulation, then we don't have all of these fluctuations in your estrogen and progesterone, and then maybe we can sort of just even out the hormones so that it doesn't affect your seizures. We looked at, so when we say a retrospective chart review, basically we looked at all of the records that we had at the Mass General and at Brigham and Women's of women with epilepsy aged 21 to 65 who were prescribed norethindrone acetate for any indication. And we were able to analyze about 14 patients. And of those 14 patients, we found that 8 of them had significant improvement in their seizures at 6 months and 1 year. And more impressively, we found that 7 of these 8 who had improvement had resolution of their convulsions, which, as I mentioned, that's the one big type of seizure that's really, really pretty dangerous, right? And we found that 43% achieved seizure freedom. And so we thought that this was pretty exciting. I'm working on trying to get a trial started so that we can study this a little bit better. It's a very well tolerated progesterone, but I think that, you know, we're still looking into different types of interventions that we can try and do to help seizures that have a catamenial pattern. And the other thing too that needs to be brought up around this time of puberty, the onset of menstruation, is really it's contraception. So it's a bidirectional relationship, meaning that, you know, some contraceptive pills will affect your seizure medications, and then some seizure medications will affect your contraception. There is a study that was done maybe a decade ago now. They looked at it was a registry of patients with epilepsy, and they found that only 38% of persons with epilepsy were on highly effective contraception. And now we have multiple options for contraception, both hormonal and non-hormonal. So there's a lot of these like interactions. And so what I always say is that if you are on a seizure medication or on an anti-seizure medication, then you start or switch from one contraception to another, just make sure that you run it by both your obviously your gynecologist will be prescribing it, but run it by your neurologist so that we're just sure that it doesn't interact, or if it does have some form of interaction, that we can try and explain this to you and try to figure out whether or not it's a good choice. So basically, you know, like I said, if you think that you have an increase or a catamenial pattern in your seizures, then try to track with a seizure and menstrual diary for at least 3 months, which helps us arrive at that diagnosis. And then again, some seizure meds will interact with other contraceptive options. So make sure you check in with both your neurologist and gynecologist for these. And then the one big thing about, you know, women and epilepsy is really pregnancy. I wanted to start off, you know, there's more and more use now of fertility treatments. We call them assisted reproductive technologies, or like IVF, IUI. There aren't any big studies that look at the incidence of infertility in persons with epilepsy. What we've found is that, and I think it's a combination of both your social determinants. You know, do you have support? A lot of patients who have poorly controlled seizures or epilepsy don't feel like they can take care of you know, a baby. So I think there's more factors than actually just infertility. But I wanted to let you guys know that, you know, we're looking into these so that when we sit down with you guys in clinic, we're able to tell you, yes, we think it's safe for you to undergo these fertility treatments. But like I said, you know, very small studies. One study just showed us that, you know, they have a similar success rate in these technologies in persons with epilepsy compared to healthy controls. And then one other study that looked at 12 patients, they found that it was safe. There's really no change in seizure frequency during treatment, which a lot of times, you know, will require some hormonal injections. But there's a lot more that needs to be studied for these. But going back to pregnancy, as I mentioned, again, hormones, right? As you progress throughout your pregnancy, hormone levels change also. Estrogen and progesterone, they increase, and then this other hormone, HCG, which we don't really look at too much. But again, these two are the big roles, right? Estrogen and progesterone. 2/3 of patients will be seizure-free during their pregnancy. So I always say this, it is safe and it's doable. From a clinical standpoint, patients with generalized epilepsy, which is a particular seizure epilepsy type, have better outcomes during pregnancy, and also if you have well-controlled seizures 9 months prior to pregnancy. And so in our practice, what we do is when patients tell me that or my colleagues send me patients who are planning to have babies, that's really the best time to sort of see me and sort of make sure that we plan everything out so that when you have really well controlled seizures prior to pregnancy, that's really the best thing. But during pregnancy, it gets pretty complicated, right? When we're planning for pregnancy, it's a fine balance between controlling your seizures, but also getting a good outcome for your pregnancy. We know that when patients have convulsions, especially, that they pose a risk to the mother and the fetus. And there are smaller studies that look at these smaller seizures, the focal seizures, but it's really the big convulsions that are scary during pregnancy and can be very detrimental to the mother and the fetus. So those are the ones that are definitely a no-no, and we want to make sure that you don't have that at all during your pregnancy. And so obviously we like to choose anti-seizure medications depending on your epilepsy type and seizure type. But one thing that we really require is what we call therapeutic drug monitoring. And so because of what I showed you guys, right, the normal physiologic changes during pregnancy, so these hormones, the estrogen and progesterone, they act on the uterus, your lungs, everywhere in your body. And what happens is that as the pregnancy progresses, the clearance of some of these seizure medications increase. So basically, even if you take, for example, your usual Lamictal that pre-pregnancy, you only take 100 milligrams twice a day. Throughout the pregnancy, you keep peeing it out, you're clearing it. So we need to keep giving you a little bit more. And so what we find is that when you have higher doses of medication, some patients will require higher doses of medications during pregnancy. And this doesn't mean that we're giving you more, that you're receiving more of it. We're just trying to maintain a nice balance to offset the fact that you're clearing it much, much more. And so in our practice, what we do is we get monthly levels of your anti-seizure medications, particularly if it's one of the seizure medications that gets cleared, where clearance really fluctuates during pregnancy, which are lamotrigine and levetiracetam, or Keppra and Lamictal. And so if you are, I always say these to my patients, try to get the levels done at the same time all the time, relative to the last medication intake. Ideally, it's before your next dose of medication. But if you can't do that, it doesn't make sense in your lifestyle to go to a lab, at 6 o'clock in the morning. And that's okay as well. But if you try to get it all at the same time, monthly, then it's much easier for us to compare one level from the other. And then also, I always emphasize this, is try to communicate side effects or changes in seizure frequency with your doctors, because anytime we make anti-seizure medication changes, we want to know. When we don't know that when we don't hear about it, then we think we're doing a good job. So if you are having side effects with these medications or any changes, then let your doctor know. So that's this part of it. And, the more complicated part is the pregnancy outcomes, right? All seizure medications, and we've been trying to study these, what are its risks for the baby? And so we look at structural teratogenesis, which basically means we're looking at like major congenital malformations, like a cleft lip, anatomical problems with their hearts, their lungs, the baby. So those are the more common ones. In the large population of healthy controls, the risk of having that is about 1.5 to 3%. So that's what we compare it to, right? Our goal is to make sure that even if you're getting the anti-seizure medications that you need to control your seizures, that we're also the risk for the baby and the pregnancy is about the same as anyone who's not on any anti-seizure medication. And so that's what we're looking at. The one other thing that we finally have a little bit more data on is about neurodevelopmental outcomes. So this first one that I showed here is structural abnormalities. The second one is like an IQ, or or the offsprings at 3, 7 years old, and what happens to them after, right? Do they have more diagnosis for ADHD and all of these things? And so to limit the risks of medications, what we like to do is we select the safest medications based on the latest information that we have. And we try to lower the number of seizure meds that control your seizures safely. And we've also found that breastfeeding is safe for majority of the time for all of these anti-seizure medications. And one of the things that has been proven again and again is that folic acid supplementation is very beneficial to prevent these structural abnormalities. We're still trying to find a consensus and exactly how much folic acid is required. And the general consensus is right now is anywhere from at least 1 milligram to 4 milligrams. And in my patients, even if they're not planning for pregnancy yet, if I know that they're at risk for pregnancy and they're on any anti-seizure medication, then I really always recommend the addition of folic acid, which I know is annoying because it's an extra pill, but it's very helpful because no contraception is 100%. And so how do we know what anti-seizure medications do to babies and all of these things? The way we study these are the registries. So here in the US, we have the North American Anti-Epileptic Drug Pregnancy Registry. And I recommend all of my patients that I see who are pregnant to enroll here. So basically, we give you a website, you go on the website, or you call this number as soon as it's usually after I see them on their first trimester visit. And it's a 15-minute phone call. They ask you questions, all of these things. And then at 7 months, someone checks in again on you. And then again after the baby is born. So as you can see, it's about like several minutes of your life. But this is all of the information, the information that we gather here from patients they're the ones that drive what we do. So for example, based on the registry findings that we've found, there's two big ones. So the North American one, and then there's also a registry in Europe. And based on these registries, we've found that valproic acid, phenytoin, and topiramate are very, very high risk for major congenital malformations. And so in patients who are of childbearing age, I tend to really try and avoid these if I can. And then another registry, like I said, I told you guys that we're looking at neurodevelopmental outcomes. They published the 3-year-old. So they followed pregnant women with epilepsy, and then they followed their offsprings. And then now these I think they're going to come out with a 7-year-old. They're like about 7 years old now, and they do a battery of like IQ tests and all of these things. And so we found that in patients who were exposed to phenobarbital and valproic acid during pregnancy, they have much lower IQs. And so far, the safest are still lamotrigine and levetiracetam. And again, the only reason why we know all of these right now is because of patients signing up for these registries so that we can follow outcomes. And it really does change practice. So again, it's a fine balance. It looks complicated, but I do think that women with epilepsy in pregnancy, it gets complicated, but it's really worthwhile to get the best seizure control and the best pregnancy outcomes because it's doable. And so again, like I said, assisted reproductive technology, or IVF, IUI, all of those things are safe so far, and it does need more studies. In terms of pregnancy, not all anti-seizure meds are equal in terms of their safety. And we do require monitoring of levels, and folic acid is very important. Registries provide us a lot of information, and breastfeeding is safe. And so I'll jump to the last part, which isn't much. So perimenopause, again, the hormones, right? This sort of shows you, again, we'll focus on estrogen, which is this red line here. just decreases all the way down. And progesterone also just sort of decreases as women age. And so um, there are small studies which show us that there's a worsening of seizures in about 40% of persons with epilepsy, and then 27%, around 27% will have an improvement in their seizures around that time. The two big things that I always sort of think about when I see patients around their perimenopausal um, age is, because of menopause, the side effects of menopause, or the symptoms that people, the hot flushes, all of those things are usually because of this lack of estrogen. And so in some patients in which those symptoms are severe, they do get hormone replacement therapy. But I told you earlier, right, that we think that, or the knowledge is that estrogen is the bad hormone. And so there are, it has to be really offset to try and see if it's safe or not, or the risks and benefits of getting hormone replacement therapy. But it's not a complete contraindication because we haven't really proven that. The other thing too is that as estrogen and as we progress to perimenopause or menopause, or bone health really suffers. So it's really important to get vitamin D levels checked, and then if it's low, to get it supplemented. And this is pretty important in patients with seizures or epilepsy, because some anti-seizure medications actually accelerate that osteoporosis. And so, if you're on a medication called carbamazepine or Tegretol, like every year or so, we're checking your vitamin D levels, even if you're not in your perimenopausal phase. So there's still a lot that we don't know about menopause, but like I said, these are sort of, if needing hormone replacement therapy, make sure you clear it with your neurologist, and also monitor seizure frequency, but it's not completely contraindicated. And then vitamin D supplementation for bone health, or at least getting it checked. And so I'm just going to go back here. Everything I talked about, puberty, pregnancy, perimenopause, these are all just normal physiologic changes. And I think it's a little crazy that we still don't know so much about a lot of these things. And, what about the pathologies, right? PCOS or endometriosis and all of these things. We don't know enough. I think there's a bunch of us that are doing our best to try and really understand and make sure that we get all of the information that we need, so that we can, provide the best care that we can for this particular patient population. So that's it. I'm happy to answer some questions.
I have a question. So what are the long-term effects of epilepsy and the treatments, especially on bone health for women?
So there are some seizure medications, and we call them enzyme inducers. So it's part of how they work, is that they actually sort of accelerate osteoporosis. A lot of these are the older generation seizure medications, like Tegretol, phenobarbital, phenytoin. And so those are the ones that actually they end up having to require more aggressive treatment for their osteoporosis.
Oh, okay. Thank you for that. And are there any like lifestyle factors that can help in managing epilepsy in women?
Not particularly, and no significant change, I would say, from other patient populations. But I think that it's really those phases in our lives as women.
It looks like Lori has a question.
Am I, whoop, am I doing this right?
Yes.
Yes, I can hear.
Okay. Quick question for you. I kind of defy all your pregnancy things, the way I
Mhm.
did things. I was an infertility patient at Yale when I was in my early 20s. And I ended up having three boys successfully. Would have been your youngest in vitro patient ever there. But recently, or not recently, but a few years back, they found that I had APS. Are you familiar with
Yep.
antiphospholipid? Okay.
Yep.
And basically all the estrogen I had, I should have never been able to conceive. well, they were giving me estrogen to conceive, but
Right.
I had so much scar tissue from previous appendicitis and peritonitis that I should not have been able to conceive. And they figured that I'd had a lot of miscarriages in the interim. But it was
Mhm.
when Dr. Wheeler was there and Dr. I can't even remember her name, Mary, I don't know, but I know she went to Switzerland. Anyway, um, they did my surgery there, but it was back in the 80s, in the mid 80s. But I went down a flight of stairs in 2008. And when I woke up in the trauma room at our hospital, they found that I had a TBI and they wanted to know why I went down the stairs. And they kept me in the hospital for a couple weeks and found that I was having nocturnal seizures. And I had only had one seizure earlier in my life, which was when I had the appendicitis um, appendicitis and what is it that goes along with that? The
Like,
peritonitis.
right.
And that was the only time. So I didn't have a history of of seizures, a steady history of seizures. So that happened when I was almost like in my late 30s when I went down the stairs. So I had managed to get through all of that. When they finally, it took like 2 years to figure out what it was, but they assumed that it was a hematologist that actually found it after 2 years, that the APS has a side effect of causing seizures. So that they finally got me on Keppra XR, which controls me pretty well. And my neurologist now is fantastic. She does a great job with me, and I have them fairly controlled, but I am also viruses and things seem to be a big trigger for me. But my main question is something that no one seems to be able to answer for me, and that is orgasms. When you are in the process of um, having, intercourse, um, obviously it wasn't an issue when I was younger, but after having the seizures, obviously you don't want to do anything that's going to provoke a seizure. How do
Right.
you manage to get around that? And no one seems to be able to answer that, from my GYN to my neurologist to anyone else, because if you get that excited, you may end up having a seizure.
Yeah, no, that's a really good question. Two things. I think, if first of all, I think the reason why we can't give you answers straightforward is, like I said, right? There's so much about women's pathologies, pathophysiologies that we just
Mhm.
it
Oh, we
has
don't know.
never
Yeah.
it's ridiculous. I think it's ridiculous. We're
Yeah.
half the population. But two things I wanted to say to that. A lot of times what I hear about, sexual either orgasms or even just whether or not their desire to have sex, a lot of my patients will say, oh, I think it has to do with the seizure medications, which again, you can't really prove until you remove the seizure medications. And
Mhm.
at that point, it's a risk and benefit. Would you
Yeah,
rather
and
have
then you run risk of dying.
yeah, so it's one of those. Could it be from the seizures? Well, the one thing is that, I think that it's unless you find that having sex and orgasm is a clear trigger, or like there are types of epilepsies or seizures that we call like reflex epilepsies, where basically, there's very clear triggers. There are some where they hear a particular sound and then that causes them to have seizures.
Mhm.
There's been some case reports of orgasms as a reflex, and so that's their sort of big trigger for seizures, but it's very uncommon.
Okay.
But the studies in neurology, at least that surround sort of orgasms and all of these things, they're mostly in the vascular realm, because when you have an orgasm, there's an increase in the blood flow to your brain.
Mhm. Mhm.
Um, And then sometimes that can cause types of strokes and all. So it's mostly in the vascular realm. We don't have much information that tells us that, having an orgasm will put you at higher risk for having a seizure.
That's kind of what my neurologist said. The thing she really couldn't give me too much of an answer, but she said that maybe holding your breath, or maybe, during, if you're too excited or whatever, and you're holding your breath, that could amount to lack of an oxygen deficit, or something along those lines with that, and that could contribute. But other than that, you're really the only person that could give an answer to. I mean, even my GYN had never really couldn't say anything to it. It's
Yeah. And I mean, honestly, I think it's not a common thing to.
No, everybody kind of goes, well, the only thing we came up with is maybe trying maybe half a dose of my rescue medicine for, like in half of an Ativan, a very low dose Ativan, which I almost never use, before, to see how that works. But, if you're single and you're trying to restart your life or something, it's a little difficult to.
Yeah. And then Ativan makes you drowsy, and then it's like this whole thing.
Yeah, it's crazy. But the Keppra XR has had a very, very good effect on me. I had a terrible problem with gabapentin, and they also had me on primopraxil,
Mhm.
and that was terrible. I had to go on a Z-Pak for a sinus infection, and between the gabapentin and the primopraxil, it made me crazy. I was like seeing things.
Mhm.
So, but that, but that's pretty much goes along the line of what she said too. So that's a good thought there. But yeah, that's catamenial, and everyone jumps to the catamenial seizures. Everyone, because that's what I was diagnosed with, is catamenial seizures.
Mhm.
And had I not had this one hematologist not listened to me, well, like, she's one of the only ones, because I kept saying, I know this isn't it. I know this isn't it. And she's the one that listened to me, and she ran the extra panels, and that's how she found the APS.
I see.
So, but yeah, this is very interesting. Very, very interesting. We know so little about it.
I know. I think that's the fascinating. I think it's crazy.
And people don't understand. There's so many things they don't get, and like even the light stimulation and things like that, when people put the crazy Christmas lights up in it, and all of that, because that's a trigger for me too, is like really bad strobe lighting.
Yep.
So, but well, thank you very much for this. It's very, very interesting, and very, very beneficial, I think.
Thanks for joining us.
Yes, thank you.
Well, thank you, Dr. Dorrance, for joining us today. This was excellent information.
Thanks, Amy. Bye, guys.
Bye. Thank you.
Have a good night.